Greetings and welcome. I'm Bruce Oviagle, the president of the Society for Equity Neuroscience. Welcome to our June edition of Disparities Dialogue. I'm honored to host this particular episode with phenomenal experts in headache disorders who are going to kindly discuss the contemporary literature when it comes to disparities in headache disorders. We have none other than Dr. Vanessa Cooper from Yale University, Dr. Rashmi Singh from the Mayo Clinic, and Dr. Roderick Spears from Brown University. Welcome.
Thank you.
Thank you.
And so we have 9 articles we plan to discuss today. The very first one looks at the issue of race and ethnicity with emergency room rate of migraine diagnosis, testing, and management in kids with headache. The next one takes a look at socioeconomic factors associated with migraine medication prescription. Our third article examines the role of income and health insurance on migraine care. Our fourth article examines sex-related disparities in migraine recognition and management. Article number 5 examines the treating of the uninsured and the underinsured with migraine in the United States. The sixth article goes beyond other and explores the representation of minoritized individuals in headache research. Article number 7 goes global and examines the global, regional, and national burden and trends of headache disorders among children and adolescents. Article 8 looks at migraine and sleep apnea, insomnia, and sleep patterns in the Hispanic Community Health Study. Article 9 looks at perceived discrimination and migraine-specific quality of life. So we'll now go more in-depth into our article discussions. Our very first article looks at the issue of the association of race and ethnicity with emergency room rate of diagnosis of migraine and its testing and its management in children with headache. It was published in the journal Neurology in 2025, and Dr. Cooper is going to kindly guide us through this one.
All right, thank you. So first, I just want to start off by highlighting that migraine accounts for 5 to 6% of global disease burden, more than any other neurological disorder combined. The aim of this study was to investigate racial and ethnic disparities in the diagnosis, testing, and treatment of pediatric patients with headache presenting to the emergency department. This was a retrospective study. It included 46 U.S. children's hospitals between 2016 to 2022. And they included patients whose ages were 5 to 21 with a primary diagnosis of migraine, headache, tension-type headache, or new daily persistent headache. Racial ethnic groups included non-Hispanic white, non-Hispanic Black, and Hispanic Latino. For simplicity, I will just say white, Black, Hispanic, Latino moving forward. Outcomes looked at the diagnosis, whether they were diagnosed with migraine. Testing included lab testing as well as neuroimaging, CT, MRI. Treatment that was done oral, IV, opioid, barbiturate, as well as disposition, was that patient admitted to the hospital. All in all, they had about 160,000 ED visits. Majority of the participants were white, and about 25% for Black and Latino. Migraine diagnosis was more common in white children, about 45%, compared to about 28% for Black and Latino children. With the next slide, I'll highlight some other differences which were noticed in this study, just to review the findings. So here, looking at the odds ratio, blue is Black, red is Hispanic Latino. So looking at the odds ratio compared to white counterparts, Black children were less likely to have blood testing, urine testing, CSF testing, as well as head CT, MRI, when they presented to the emergency room. Thankfully, there were no statistical difference between who received opioids or barbiturates. Black children and Latino were more likely to receive oral medication only, and then they were less likely to be admitted to the hospital. So this highlights the major findings of the study. We can go back. So limitations, so difficult to assess appropriateness of testing treatment in this study for these patients. There were incomplete reporting of race and ethnicity as well, and then a lot of confounding variables as it relates to insurance status, language barriers, as well as socioeconomic status. But the conclusions from the study, all in all, were that Black and Latino children received fewer migraine diagnoses, less testing, notably MRI, and less intensive treatment, so more likely to receive oral-only medications, as well as less likely to be admitted when compared to their white counterparts. Implications from this, so inequity, there is an inequity in migraine diagnosis. This is important because it definitely shapes the pathways and also affects who gets migraine specific treatment, who gets to see a specialist if they're not being diagnosed with migraine initially. And then implementing standardized evidence-based migraine pathways can help to reduce these disparities in the future.
Thank you, Vanessa. An interesting study. And of course, the big question here is these are striking differences, but we don't know what's good or what's bad or what's neutral. And so the question is, how do we interpret this less testing, this less intensive treatment in these minoritized populations? Is it under treatment? Is it appropriate care? Is it both?
Yeah. So looking at the study, they did exclude what they thought to be secondary headache, right? So we're assuming that this is strictly headache, no red flags, migraine, no red flags. So technically, for following the standard of care, these patients should not need head imaging. So just because, a certain group is getting under, I wouldn't say under treatment. I would say there's a certain group that's receiving over treatment, right? So there, and over treatment does not necessarily equal to better care. It does increase utilization within the emergency department, increases cost. And I think it's important to look at why this happens. Why is there an overtreatment in a very specific population, right? Um, there are a lot of confounding variables, whether it's socioeconomic status that relates to more health literacy. They're aware of what can be done in the emergency room and they ask for these things. Is there influence of insurance status? So if a patient doesn't have insurance, maybe their provider is less likely to recommend more aggressive forms of treatment or testing just because of the cost. So I think there's a lot of factors involved, but I think one of the main things is that there's 100% of overtreatment within a very specific population.
And thank you. Those points are very well taken. I don't know if Rashmi or Roderick have additional comments or questions on this one.
Yeah, I'll chime in. I'll say that, when I looked at the study, what really struck me is that it validates that patient experience. We hear from our patients so much that their pain is often not taken seriously. And this is often something that we hear from our patients who might be of color, patients who are minoritized, especially, or as a clinician, I hear this many times from my patients of their experience in the emergency department and maybe why they have a reluctance to go seek care in the ER as well. I'm an adult neurologist. I don't really see pediatric patients too frequently, but this really is something that I think is important to note that it happens not only in the adult population, but from the study, we see that it can happen in our pediatric patients as well. And I think as a clinician, something that we should really think about is that when patients come in to check our own biases, because there really is something to be said about the fact that this happens from the perspective of a person's race, that we make these differences. And I think that physicians really want to do the best that they can for every single patient that we see. But if we can take a look at what the studies tell us, there is an unconscious bias present, and I think we should just be aware of that.
Yeah, great points. Roderick, any additional?
No.
Great, great. Thank you. All right, we'll move to the next one then. And so the next article published in Neurology Clinical Practice looks at the issue of the relationship between socioeconomic factors and migraine medication prescription at a tertiary headache center. And Dr. Cooper is going to kindly guide us through this one.
Okay. So the aim of this study was to assess whether demographic and socioeconomic factors associated with prescription of acute and preventative migraine medications, as well as factors affecting the rollout of novel migraine medications. So this was a retrospective cohort analysis at Stanford Headache Clinic in California. It was from 2018 to 2022, included adults 18 and older in California who had received a diagnosis of chronic migraine and received at least one prescription medication from a clinician at that clinic. Key variables included age, sex, race, ethnicity, zip code, income quartiles. And then they analyzed the the most common acute and preventative medications. This included about 4,000 patients. The studies did find that older patients were less likely to receive triptans, more likely to receive lasmiditan. Men were significantly less likely to receive any type of acute medication, um, as well as Hispanic Latino groups received less likely to receive any type of specific migraine medication as well when compared to non-white Hispanics. Income, so the highest income quartile showed slightly increased triptan use. Older patients were more likely to receive Botox. And then minority groups had significantly lower rates of CGRP monoclonal antibody prescriptions versus white patients. And what I thought was really interesting was that patients in the second and third income quartiles had the lowest prescription utilization rates. The highest were actually in the first and the fourth quartile. And then Asian and Hispanic patients were least likely to receive dual or triple therapy, which is the most expensive treatment options that we have for migraine, including the monoclonal antibodies, GPANs, as well as Botox. So limitations. This was a single center study. No insurance data was available. Zip code was used as a proxy for that. We didn't capture any non-binary patients. And then some groups were under represented as well in this study. So conclusions, there were significant disparities in migraine prescription by sex, notably men less likely to receive migraine-specific medications, as well as race, ethnicity, and income. Minority and lower to middle income patients were less likely to access newer and more effective therapies. And then many minority patients appeared to arrive at the clinic without having yet trialed any standard first-line medications. And then the donut hole effect, which I touched on partially, but essentially there's like a hidden vulnerable group who is not having access to some of these newer medications as well. So implications, being aware of biases when we're prescribing, being proactive about patients who are unable to utilize some of these medications, maybe due to cost, letting them know about any savings programs that manufacturers may have, and then advocating for better insurance coverage to kind of capture this middle group of patients who are not able to have access to these newer therapies.
Thanks, Vanessa. Another fascinating study and not straightforward, right? Typically, we like a kind of dose response kind of relationship, but here we have this donut hole income effect, and it's quite interesting. I think would love to glean from your own clinical experience. What are the real world insurance or financial barriers that could create this donut hole income effect? And what practical strategies would you recommend that your fellow clinicians use to try and help this hidden vulnerable group of middle income folks?
Yeah. And I think it's like it goes across many things outside of just, medicine, this middle in class group, right? So it seems as though in real practice, I have my Medicaid patients, right? They will have access to all of the great migraine medications for zero to low cost. I have my patients who have excellent insurance. They're also able to have access to really great the migraine medications for really great coverage and cost. But then I have this middle group, right, where they're lower income, but too much money for Medicaid, but don't really have great insurance through their job and covers their bare minimum, and they have extremely high deductibles. And the deductibles lead to, crazy amount of copay, which they cannot afford, even though we may recommend a treatment, they're just unable to pick it up. But having access, like I said, to these drug manufacturer programs kind of helps to offset some of those costs. But there is definitely, it highlights that we need to advocate for more insurance coverage, especially for this very vulnerable class of patients.
No, thank you for that. And I think the other question is, based on this, and I know, of course, as you mentioned, the limitation here is that it's single academic center, but does it inform us as to where the real breakdown in equitable migraine care might be happening? Is it happening potentially at the primary care level, potentially at the specialist access level, or something deeper along the lines of what you just mentioned? What are your thoughts?
I think all three. We know that majority of patients who have migraine or headaches are seen in the primary care setting, and this study did highlight that they were underdiagnosed and undertreated before they even got to their specialists. So there seems to be a breakdown either in the primary care setting with the diagnosis and starting treatment of migraine, and then access to a specialist. Whether they're in a rural area, they may not have access to a specialist. The access to a specialist may come with a very, very long wait time as well, which we're seeing in real time. So I think a lot of these factors play a role in these disparities.
Thank you. Rashmi, Roderick, comments? You're both good? All right. Roderick, go ahead, please.
I was just going to say that this seems to be just an ongoing problem for many years, and we talk about how to lift up headache care. Do we educate other providers? Do we recruit more headache specialists? I think yes to both, but these are not easy things to do, and it's just frustrating. I just wish wish we had a better plan for how to address these disparities.
No, absolutely, and a great point. And I think part of what we are trying to do with sessions like this, and again, I thank all of you as experts for weighing in with your expertise and experience, is trying to sensitize people, especially policymakers. Again, I don't think anyone has all the answers, but hopefully we can inform people as to what the issue is, and hopefully with time, these very knotty problems might be untangled, so to speak. So, yeah.
I was also interested by the fact that Asian and Hispanic patients were least likely to receive dual or triple therapy, and wondering why that could be, right? Is it a socioeconomic issue? Is it a language barrier? Are these individuals less likely to speak English and they didn't have appropriate interpreters? Is it something else? I think that's an interesting aspect of this that we don't have full handle on either.
Touche, no, absolutely.
Yeah.
Yeah, no, I wonder how that aligns with, again, this is one study at a single academic center, whether that also aligns with other studies of this type, and is that also seen there or not? But to your point about language barriers, that could definitely explain it potentially.
Yeah.
All right, we'll go to our third article, and this one examines the role of income and health insurance on migraine care, published in Advanced Therapies in 2026. And so Dr. Cooper is going to help us through this one. Thank you.
Okay, thank you. So essentially, prior research has identified income and insurance as barriers to care, but where care is received has not been well studied. So this analysis aimed to fill that gap by using one of the largest migraine data sets that we have. So Overcome was a US large web-based survey that was conducted annually between 2018 to 2022. It included 5 income groups that were studied, and the key questions asked were, did the patient receive care for migraine? Where did they receive their highest level of care? And then were they using recommended acute and or preventative medications? So the findings of this study included lower income persons were twice as likely to rely on emergency urgent care as their highest level of migraine care. Higher income individuals were also more likely to use recommended acute treatments. Insured individuals, all in all, were more likely to see a specialist, use recommended treatments as well as preventative treatments as well. And then the benefit of insurance was greatest for low income individuals and diminished at higher income levels. And then I have a summary. Yep, exactly. So looking at looking at the 5 income levels, at the higher income level, you can see that in the burgundy, more likely to receive specialist care. And then the lower income level, they had a higher ratio of receiving their highest level of care in the emergency department. And then on the right, the higher income level were more likely to use recommended acute and preventative medications, as well as CGRP monoclonal antibodies. And then lower income levels were less likely to use acute preventative migraine therapies, as well as CGRP monoclonal antibodies. We can go back. So limitations, this was a survey required English literacy as well as internet access. So this will exclude patients who are not proficient in English, and there's some language barrier. This required patients to recall, so there's some recall bias with self-reported data, and then gender was not collected in this survey as well. So conclusions from the study was that lower income was a barrier to access and appropriate care, even after accounting for race, ethnicity, and other factors. Having insurance significantly reduced this disparity, but did not eliminate the impact of low income. And then income affects where care is sought, and then the disparity gap is widest for those who are both low income and uninsured. So implications, untreated migraine leads to more disability, lost productivity, and perpetuates the cycle of poverty, and closing this care gap will ultimately, hopefully, lead to expanding, like we spoke about earlier, Medicaid and Medicare eligibility, reducing out-of-pocket costs for patients, expanding telemedicine, access, community health resources, et cetera.
Well, thanks, Vanessa. Now, this study obviously was done 8 to 10 years after the Affordable Care Act was passed. Yet we did see significant income-based disparities, even among those who were insured. And so what does this tell us in terms of the limits of insurance coverage as a solution, and what potentially could be other systemic changes that would actually move the needle for low-income migraine patients?
So I think one of the important things that this study highlighted for me, which I mean, I was aware of, but didn't really sit down and think about, is that having insurance is not enough. We always think about, oh, we advocate for patients to have insurance, we should have insurance, but having insurance does not equal to meaningful access. And I think that is where the problem lies. So getting, decreasing deductibles for so some of these patients' plans. In real world example, when I have a patient on Medicare, my heart sinks every time I see them. Just because I know majority of the time they will not be able to afford the out-of-pocket cost for what I'm about to recommend. And that is very unfortunate. Typically, for all the CGRP monoclonal antibodies, the copays are around $400, $500 out of pocket, and they're on fixed income. Even though they have insurance, it's just not realistic.
No, agree. Rashmi, Roderick, any other comments on this?
So
Roderick, please.
For my Medicare patients, I will typically think of Botox injections because that's covered.
Yep.
I will think of eptinezumab or Vyepti because that's typically covered, although they do have a portion they have to pay for both of those treatments.
Yep.
But I do tend to, I guess, approach my Medicare patients with kind of some specific recommendations in mind. Not that I don't present the others, but I kind of expect, like what you just said, Vanessa, that they're going to get hit at the pharmacy and it's not going to be an option.
And Roderick, let me ask you out of my own ignorance, and asking all of you really, is that type of approach widespread among headache specialists trying to, pick or is that not necessarily the case, trying to pick the medications that are covered as opposed to those that might not?
I think it's something we all have to consider, because if we keep recommending medications that we know our patients don't have access to, that just doesn't make sense. And everyone gets frustrated, us and the patient. So I think it's something we definitely have to think about, whether it's driving our decisions wholeheartedly. That I can't speak to, but it's a consideration.
Absolutely.
Yeah, I would agree with this. I mean, this comes up in my practice all the time. As recently as yesterday, where patients explained to me about the cost of medication, right? So the patients bring this up, and they really want us to be proactive about thinking about the cost of treatments that we recommend to them. So I think it's important.
Yeah, no, it absolutely is. I mean, I think part of the issue, and this is not just limited to the treatment of headache disorders, but it's us as physicians or providers incorporating this issue of the social determinants or drivers of healthcare and into what we do on a routine basis. Even when patients don't bring it up, or we're really trying to figure out what is going to allow our patients to follow through with the therapies that we prescribe. So no, thank you. All right. We're going to let Dr. Cooper off the hook a little bit here, and then we're going to go to our fourth article. And this is examining sex-related disparities in migraine recognition and management, insight from a tertiary headache center cohort. It was published in the Journal of Headache and Pain in 2025. Dr. Singh is going to help us understand what happened here.
So we've already discussed that migraine is a very prevalent problem, and there's a sex difference with this condition, with migraine being identified as much more common in women compared to men. This is a paper that spoke to that gender or sex difference. The authors shared that migraine is about 2 to 3 times more prevalent in women, and this has contributed to its mischaracterization as a woman's disorder. The authors shared that women are the ones that really share that their symptoms are unilateral, have pulsating pain, and have photophobia, phonophobia, those canonical symptoms as part of their symptom complex. So what they did was a retrospective cross-sectional study. This was from Germany. It was a single center that had over 1,000 patients diagnosed with migraine, and they analyzed the sex differences and as well as prior diagnosis rates and clinical presentation and treatment history before and after their evaluation. What the authors found was that men were significantly less likely to have had an accurate diagnosis of migraine prior to referral. This was statistically significant. The odds ratio was 0.47. And what they found was that the symptom presentation is also very different. So men reported a lower pain intensity and also a shorter attack duration. Women were more likely to report having unilateral pain as well as nausea, vomiting, photophobia, phonophobia, osmophobia, and having those typical symptoms meant that women were more likely to be given an accurate diagnosis of migraine. In men, they were more likely to report having a pressing quality to their pain and also having bilateral pain as well, which meant that they were more likely to have a missed diagnosis of migraine, being given a diagnosis of something else rather than migraine. Additionally, women were more likely to have been given triptans prior to this referral, which actually mirrors a previous study that we already discussed. And what the authors concluded is that women were more likely to have been given a diagnosis of migraine compared to men. And this likely accounts for the symptom presentation differences between men and women. The authors recommended that we think about these differences when we make these diagnoses as well, and how these typical symptom frameworks can create blind spots in our diagnoses when they don't really meet that symptom prototype.
Fascinating. Yeah, no, really fascinating. What comes to mind, of course, is that it seems like there's this machismo effect here going on. And so I guess the question is, men are seemingly underreporting their own symptom burden, likely because of stigma around expressing pain. And so how much of this gap in diagnosis, sex-related wise, is an issue that comes from the clinician angle versus comes from the communication angle on the patient's part? And how should we as clinicians potentially do a better job in our history taking to try and elicit the symptoms that men may be less likely to voluntarily express?
That's such a good question. You know, after I read this paper, I went back and thought about all these men that I saw in my clinical practice who I wondered, you know, they came in, talked about their pressing pain, and they felt like it didn't impact their physical ability to function quite so much. And we were like talking about a diagnosis of tension type headache. And I wondered, were we missing a diagnosis of migraine in those individuals because of those symptoms that they reported? And, you know, I think it's on part of the clinician, but maybe on part of the patient to really recognize what they're experiencing as well. And I think you're absolutely right, Bruce, that it has a lot to do on both sides, because as we all know, migraine is highly under-recognized by society as a whole, right? Most people who have migraine don't even come to see a clinician for their symptoms. They live with disability quite a bit. And when they do come to see a clinician, many of us don't recognize it either. And I think what this paper really pointed out to me is that once a patient does come in to see us, we need to ask the right questions to make that diagnosis. And not everyone who has migraine will have throbbing unilateral pain. Not everyone has nausea or photophobia or phonophobia. And we all define disability differently. It's not always based on physical disability either. So as a clinician who takes care of patients, I had to pause when I read this, especially when I see a man who comes in with headache, because I have plenty of those in my practice. And many times they do come in with this bilateral pressing pain symptom. And I think I need to reframe my conversation a little bit. And I think as a society, we need to have more social media campaigns about men with headache and men with migraine, what that presents like. But when they finally do come to see me in clinical practice, I think I should be asking my questions a little bit differently and reframing that to how maybe it impacts their quality of life, not so much on the physical disability.
Makes a lot of sense. And I do wonder, again, of course, this was single center. This was done in Germany. I wonder if there are differences across cultures to more pronounced in some, less pronounced in others. It's just a fascinating exploration of this issue. The other question I have is, should we be doing anything about current diagnostic criteria? Do they need to be reconsidered in any way? Or should we really, to your point, be trying to just have better clinician education, better patient awareness around this issue and trying to destigmatize, so to speak, this problem? Yeah.
You make some great points about the limitations, because obviously this is a single center study from a very specific culture and community. So who knows if this would be different in the United States, where we have more diverse cultures represented. But I think as clinicians, we should kind of keep an open mind when we see our patients. And to your point about should we be, changing up our criteria? Well, this is a great time for the International Classification of Headache Disorders to think about that, because that is actually something that's being discussed, right? So the ICHD, we're in the third iteration of that, but the classification committee is meeting right now to discuss the fourth iteration. So maybe they can take that into mind. Maybe migraine affects more than 6% of all men. I don't know, because this is the data that we have, and these are the diagnostic criteria that we have. So maybe we should be thinking about that. But I think in the meanwhile, before the diagnostic criteria is changed, if it becomes changed, we should probably be asking our questions a little bit differently, especially when we see a man in clinic who comes in with headache symptoms.
Here. Roderick, Vanessa, any additional comments or questions?
I think one question I have or comment is, if the diagnostic criteria is changed, how do we get our primary care doctors, our emergency room doctors to use this criteria so that they can accurately diagnose migraine before the referral? I think, this highlights, men were significantly less likely to have even the diagnosis before they even got to us. So how do we encourage our colleagues to use the criteria that's even there, so that they can get the diagnosis to begin with?
When I see my guys, I'll bring in things like family history, childhood variants of migraine to kind of get a sense of what's going on. And I'll usually mention to the guys that, these headaches are significant. You may not be meeting criteria for migraine, but you're here. Everybody's busy, and you took the time to come in and wait, and be seen. So these headaches are getting into your life, causing disability. So it's kind of a therapy session I have with my guys the first time, where we kind of talk through stuff. And usually by the end, they're pretty convinced that, okay, it is migraine, even though it's not something that they came in expecting to hear.
No, well, you both raised fascinating issues, Vanessa, about the issue of primary care and trying to address this upstream. And then secondly, now, of course, Roderick, you've now triggered something else in my head about provider-patient concordance, because when you said, my guys and everything, I wondered, are men more comfortable being more vulnerable with men versus women headache specialists? I have no idea. But when you said that, it just made me wonder to what extent that plays in. Not that that should change the way practice patterns are, but it does make one wonder if, whether it's for men or whether it's for women providers, whether there are some sensitivity awareness things that could make people feel more comfortable either way to express their true symptomatology. I don't know, but that was fascinating just listening to you talk about like that. Yeah.
So the data is out there for African American men that their preference is an African American male physician in headache. So there are not that many of us So, but that is a preference that African American men have expressed. And
Interesting. All right. Well, that's good. I learned a lot there. Thank you so much. All right. We'll move to the next article, number 5, which looks at the issue of treating the uninsured and underinsured with migraine in the United States, published in Current Pain Headache Reports in 2024. And Dr. Singh is going to help us understand what they did and why.
So this was a narrative review. It actually builds on conversations that we've already had in this webinar, basically that the authors looked at, they discussed the fact that people who have migraine face already a lot of healthcare costs and disability, which can impact their insurance status. But there's this, bi-directional effect, whereas their socioeconomic status, as well as the life burdens that they live with, can also impact migraine as well. It goes both ways. Also, where they live, their access to care can also impact how well their migraine is treated. So it's a confounding effect, essentially. The authors commented that migraine prevalence is higher amongst the uninsured Medicaid patients versus those who are privately insured. Uninsured patients are twice as likely to receive triptans. Twice as less likely to receive triptans. That's a mouthful, and also less likely to receive preventive medications. Additionally, those who are Black and Hispanic are less likely to receive an accurate diagnosis of migraine. They commented about discrimination contributing to diagnosis of care. Those who are in rural areas have less access to care, as well as to devices which can be cost prohibitive and not always covered by insurance. This paper obviously had a lot of limitations because it's a narrative review. The papers it relies on are of various quality as well. Uninsured patients are often not captured on claims and clinical databases, so really the true disparities are not well captured. But ultimately, what the authors were able to conclude is that the health disparities in these populations are multifactorial and ultimately result in delayed diagnoses, suboptimal treatment, and this also eventually perpetuates their migraine situation. And the implications is that we need multiple things to happen, from policy advocacy to things to improve the workforce, to possibly telemedicine, to community-engaged research design, and really practical tools to make sure that these individuals get the access to the medications and treatments that they need. So I read this, and I think it really just builds upon the conversations that we've had about the complexities that are present within our patients who live with migraine, and also the challenges that many individuals have within this framework with access to appropriate care and medications as well.
Thank you, Rashmi, for that. And in the context of this, one wonders, how do clinicians begin to rebuild trust with patients who've had these types of experiences? And what specific changes could help prevent of symptoms from beginning in the first place?
Yeah, that's such an important question. And I really think that to rebuild trust, it comes down to something very basic, which is really listening to our patients. I think we have to really allow them the time to speak, share their story in that clinical encounter, and listen and let them know that we hear them. We hear their individual story, their story matters, and really validate their symptoms and what they're living with. Sometimes, I tell my patients, most of the time, I can't cure their migraine situation or their situation that they live with, but at least I can listen to them, and I can at least try to support them through their migraine journey. And I think at least that much means a whole lot. I'd love to hear what my colleagues have to say about this, because I think this is a big problem, and I'm open to any recommendations and tips that they also have as well.
No, thanks, Rashmi's opened it up, and Roderick already has solutions.
Well, I would agree with you, Rashmi. How many patients do we see as headache specialists that have had bad experiences, not just based along ethnic lines, but just in general about their disorder, not being listened to? And when you take the time to actually listen to them during that first visit, and they get the sense that you're going to partner with them and work with them, they know there's no cure, but it means a lot to these patients. And so I just agree with you, Rashmi, everything you said.
Yeah, I echo the same.
Yeah, no, it's interesting. Um, if I may, Rashmi, another question would be when patients in these type of situations can't access first-line preventive or abortive therapies, when does good enough care look like in that? What does it look like in that kind of context? And how do you, being an expert headache clinician yourself, counsel patients about the balance of harm reduction against optimal management when those ideal options clearly are not on the table?
That's such a good question. And I think that good enough care really has to be individualized for that individual patient and their individual situation. I think this is where the art of medicine comes into play, and also really truly knowing the patient. I work with a lot of medical students and residents, and I tell them that this is where that social history becomes so vital, right? Like I want to know where like who does my patient live with? I want to know what they do for work. I really want to get to know my patient so that I can come up with a care plan that will be effective for them and meet their specific needs. Because if I don't know all of that, I can recommend anything I want, right? I can recommend the sky. But if it's not applicable for my patient, then it doesn't make a difference. And right, so I think this is where really, and my individual plan for a patient, it might not be the latest medication, but if it's something that they can afford, it will meet their specific goals, then it might be good enough in that moment. And maybe they can work, maybe they can get to work, maybe they can get to work, maybe they can, maybe they can put food on the table, maybe they can get the job promotion that they need, maybe they can keep their health insurance. So I think we really have to tailor it to the patient. It really takes getting to know each patient on a personal level to meet those specific needs.
Yeah, no, point well taken. I always say that my headache specialist colleagues have a higher ranking in heaven than the rest of us because of the way you have to approach a very challenging and often recurring problem. But I guess the question I would have, if I may ask Rashmi, just based on your experience, because I endorse everything you just said, but one of the pushbacks I've heard from people is in that very narrowly defined encounter that you have with the patient, how is one able to get to know the patient in the type of ways that one should in order to make sure you tailor the therapies appropriately? Some people are extremely efficient naturally, but most of us are not. And so, any tips you or Roderick or Vanessa can share about how you approach it to try and do that in that limited time you have with them?
Yeah, I mean, I think asking open-ended questions doesn't take as long as sometimes we think it might. Um, like people think sometimes that, oh, if I ask open-ended questions, the patient's going to talk forever and my whole time is going to be taken up. I won't be able to get through my questions. They actually stop talking and we can actually get through the questions we need to make our diagnoses. But if we allow for a little bit of connection to happen, it makes a big difference. And like I tell my medical students, don't skip over that social history. So that's where the connections happen and really knowing what's important to the patient.
Well said. Anything to add, Roderick or Vanessa? Are you good? Good. All right. Lovely. Our sixth article, entitled Beyond Other Exploring Representation of Minoritized Individuals in Headache Research, was published in 2025 in the journal Headache. And again, we are honored to have Dr. Singh talk about this particular article. And we're going to reserve especially difficult questions for her at the end of this, because again, we have her as an author to present this. Of course, I'm kidding, but no, thank you. Congratulations on this great article, Rashmi. Walk us through it, please.
All right, so this is the work of so I was the fellowship program director when Dr. Cheng was my headache fellow, and this is really her work during her fellowship. But with this paper, we decided to look at well, let me just back up for a moment. So we know that health disparities are well documented in the headache medicine literature. However, we don't really have a great understanding of how well those who are of Asian background are represented in the headache medicine literature. So what was done was we did a systematic review of original research and randomized controlled studies published in what we thought were the three major journals in the headache medicine field. This includes Headache, Cephalalgia, and the Journal of Headache and Pain from January 2020 up until January 2024. We used US-based studies only. And what we extracted was whether race and ethnicity was reported, and whether conclusions were stratified by race and ethnicity, and the average proportion of Asian participants when reported. Out of about 1,000 articles that were screened, a little over 300 met criteria, a little over half reported race and ethnicity, about a third did not. And reporting rates varied widely by group. So, most reported white, Black, Latino, Hispanic, as well as Asian and so on. But what we really wanted to point out is that among studies reporting Asian participants, the average representation was about 3%, which is well below the US benchmark of 7%, which is the US population of Asians. And no studies at all performed Asian American subgroup analyses, because as we all know that Asians within the US are a very diverse population. Their study was had many limitations I want to point out. It was retrospective. We limited only to 3 journals, and we did not do any kind of risk of bias assessment. Really, Dr. Cheng was the one who did the screening and extraction. But really, I think what we wanted to point out is that there's many gaps that remain in our understanding of race and ethnicity across the headache journals. One thing that we did find was that this category of Middle Eastern North African, or MENA as it's now called, was entirely absent. We had no data on that population at all, which is now included in the US Census. And Asian Americans were notably underrepresented in headache medicine research, despite not being underrepresented in medicine as a whole. And our implications of all of this is that we really do need to think about this when we're conducting research within headache medicine. And also, desegregating the reporting is important to be able to avoid perpetuating disparities in different groups.
Yeah, no, thanks, Rashmi. And I think I'm going to ask, because I'm ignorant of this, is this when there are international studies of headache? And so these, of course, were US-based studies. Is there also that similar underrepresentation in your experience?
Not necessarily so. I mean, I was actually just looking at cephalalgia this morning, and there was a paper published there that was talking about prevalence of migraine in the South Asian subcontinent. And it talked about migraine prevalence in India and Sri Lanka as being about 25%. And also we know from international reports that migraine is highly prevalent in Southeast Asia, of about 25 to 35%, depending on which community we're looking at. So that's extremely, we're talking about 1 out of 4 to 1 out of 3 people, depending on which Asian community. So the fact that these individuals are completely not represented at all in our American literature, I think is a big gap.
Agreed. And I think the other issue here, and it's not just limited to headache, is, as you noted, because NIH tends to mandate this demographic reporting, that's helpful. But we also know, and I think this applies to headache as well, that there are lots of industry-based studies, and they don't necessarily do this on a routine basis. And many other countries do not have that kind of requirement. In fact, many other countries, they don't really break things down by race or ethnicity per se, especially Western countries don't necessarily do that. And so I just wanted your thoughts. Maybe you disagree with that observation, but I have observed that beyond the NIH, as you noted, more broadly, especially industry, and they're recruiting very, very quickly, there isn't as much of an emphasis on the issue of trying to make sure there's broader representation. There isn't a requirement. Money's on the line many times in terms of that. And so that's not always the case. And then more internationally, there isn't that culture of research infrastructure needing to be as representative as possible. Again, I could be wrong. That could be my own lens. What are your thoughts, please?
Yeah, I think it's important to be as inclusive as possible with research, just so that we can make sure that we're not missing any potential opportunities to treat appropriately, So I think that is important, especially when we're talking about the United States and different needs of different communities. We've already spoken about different findings that we've identified in different manuscripts here. And I think there are likely gaps in Asian communities as well. There's a myth that Asians likely don't have migraines has been shared, many times. That likely, I mean, it's been published in different manuscripts as well. But when you break it down, that's what I think where the problem is. Because Asians are not a monolith. There's so many different communities amongst the broad umbrella of Asians. That's where I think the problem lies. As I just mentioned, South Asians, it's like 1 out of 4, or Southeast Asians up to like 1 out of 4 to 1 out of 3, depending on which community. But when we lump it all together, we really have missed opportunities to really identify people of need and people where we can make a big difference.
I see. I'll invite Roderick. Vanessa, any comments, questions? Rashmi, are there specific strategies that you're aware of for bolstering recruitment of this diverse Asian population into studies that you're aware of?
Yeah, I think we need to be more intentional about our research studies to make sure that we're inclusive of really everyone in them, including our Asian patients. Some of it might be language as well. Some of these individuals don't have a good handle of English language. There might be cultural biases about approaching research, or even clinical trials, things like that. Also, cultural biases about pain representation and pain, reporting. So I think those are all things to think about.
Absolutely. Thank you. Great study, great discussion. We'll move to our 7th article. This looks at the global, regional, and national burden and trends of headache disorders among children and adolescents. Looks at a broad period published in BMC Neurology in 2025. Dr. Spears is going to guide us through this one.
Sorry about that. As you said, this looks at the global burden of disease from 1990 to 2021. The data was analyzed for incidence, prevalence, and years lived with disability of headache disorders in individuals between 5 and 24. They extended adolescence to 24 to include what the authors called the more advanced adolescent these days. And what they found was that the global incidence of headache disorders rose from about 236 million in 1990 to 290 million in 2021. Migraine accounted for about 45 to 46 million cases, and tension type headache for about 245 million cases. The highest age standardized incidence rate of migraine was seen in tropical Latin America, and we'll circle back to that a little bit later. Whereas the highest income in North America and in Europe, they saw the highest age standardized rate of prevalence. Global prevalence of headache disorders reached 812 million approximately in 2021, a 23.72% rise from 1990. And then finally, high social demographic index regions bore the highest burden, while middle or social or SDI regions exhibited the most significant increase over time. The limitations in this study was that it relied heavily on estimates of subnational, which may obscure subnational disparities, particularly in data sparse, low, middle income countries. They don't have the structure to really do these studies. And then there was lack of granular data on modifiable risk factors like screen time and dietary habits, which limited the causal inference that we could make from the study. So the conclusions were that there are rising burdens of headache disorders among children and adolescents worldwide, with significant regional disparities in incidence, prevalence, and disability. And the implications our findings call for targeted public health policies, improved health headache awareness, and strengthening healthcare systems to mitigate the impact of headaches on young populations.
Thanks, Roderick. Interesting study, and of course comes with all the caveats, as you mentioned, of studies of this nature. Having said that, while on one hand, there was an increase in both incidence and prevalence in the global north, the fastest growth was in Latin America and, to our previous conversation, in East Asia. How do you interpret these findings?
So it makes sense that there would be an increase in prevalence in Western Europe and in the North because of our healthcare systems and our ability to make a diagnosis and accurately treat these patients. We've gotten good at being able to treat these patients because we do it a lot. On the other hand, the burden would be greater in Latin America and East Asia, where they don't necessarily have the diagnostic tools, don't have the headache specialists, and don't have the resources in their healthcare system to address the issues in the population. And the people that do practice headache medicine in those areas or are taking care of headache patients maybe are not doing it on a regular basis like we are in the West and in the North.
And I think for me, one aspect that was a little bit intriguing, if not alarming, was that one, of course, on one hand, this study built on prior work by including younger age children between the ages of 5 and 9, but it revealed an emerging acceleration of migraine in this age group in the high middle SDI regions, which had not been previously observed in adult populations. What do you think about this in terms of risk factors and how to address it potentially?
So I definitely think it needs to be addressed because there's evidence that misdiagnosis in a young age puts a person at higher risk for chronic headache disorders, chronic migraine in adulthood. But children now are dealing with more screen time, more disrupted sleep, um, and other risk factors that we had not identified previously. So I think this was an important cohort that they identified, and they were able to pull out some of those risk factors to maybe modify our approach to prevent long-term negatives with chronic headaches in the future.
Yeah, well said. Well said. Rashmi, Vanessa, any additional comments or questions?
I have a comment. With this growth and burden of migraine worldwide and in this population, I always wonder, like, how do we tackle this? How do we get more neurologists in these areas, more headache specialists in these areas? How do we increase education? So I'd love to hear your thoughts.
Well, I guess expand on my experience here at Brown over the last 4 years that there's a lot of excitement about having a headache specialist and developing a headache program, but not necessarily an interest in becoming a headache specialist. Um, and so my approach has been to try to increase education and equip people to the point where they're able to at least get patients started because we know the majority of our patients are going to present to their primary care physician with this complaint before they would ever get to a specialist. And then try to identify champions that are interested in becoming um, not necessarily headache specialists, but champions in their space, internal medicine, OBGYN, whatever it is, where they have an interest in this, and they can participate in education and kind of preceptorship of medical students and residents.
As I mentioned, being a headache specialist is a special calling, and grateful to have colleagues who do this. I did want to piggyback on what you asked, Vanessa, in terms of more neurologists. So I am privileged to do a lot of work in sub-Saharan Africa, and the truth of the matter is I suspect many countries in the global south will not be equipped anytime soon to have the type of resources to train neurologists. If anything, the few neurologists oftentimes leave and go to the global north, thereby even draining the few resources that they have. And so my question for all of you headache experts is, in these under-resourced, low to middle income countries, have there been attempts to try and train physician extenders, neurologist extenders, headache specialist extenders to try and at least broaden the impact of being able to develop, to diagnose, and also address headaches? Again, I don't know this. I'm trying to extrapolate from stroke and see if that's happening in headache at all.
There is an effort going on by the International Headache Society. I know that Dr. Rami Bernstein is going to many different countries in Africa, in Asia, Kenya, Philippines. There are some places, Mexico, he's been going to, really to educate the clergy, actually, because people go to their churches, right? And educate with how to recognize migraine. So mainly, the ID migraine diagnostic list, the screening tool, which is you ask 3 questions, so asking about impairment, nausea, disability, and educating the nuns and the priests to really recognize migraine. And also sumatriptan, I guess, is on like the world medication list. So really just, can we identify migraine? Can we get appropriate people on at least sumatriptan? And maybe that will be helpful in making a dent in this global problem. I think it's an innovative idea because just like you mentioned, Bruce, we don't have enough neurologists, but people at least go to see their priests and people of their faith. So maybe that's a way to make a difference. Let's see. But I look at this and it's like, this is the future. This is the future of the world with these young people. And if they're impacted by migraine, I mean, this really impacts the trajectory of their life. And many of these people go through life without a clear diagnosis, but even without a diagnosis, it impacts their life, right? So if we can diagnose them and get them treated, that's really important.
No, that's highly innovative, and I hadn't heard about that, which I'll make sure I go and read about. I think the other aspect to this is that, and again, I speak about Africa because that's where I know the most, is that on one hand, where there is a paucity of resources, there is high penetration of mobile phones and devices and things like that. They're relatively cheap. And so lots of people have, and so many kids in those areas are utilizing those devices, not unlike our kids a lot better because they're able to get them cheaply. So again, to what extent that might contribute to the increase in headaches in places that are otherwise poorly resourced is an issue. The other part of it, because you prompted that, Rashmi, is that one of the issues that we face when we do work in sub-Saharan Africa is the issue of the traditional healers, because many of the individuals in the population go to their traditional healers to try and address headache issues, other issues as well. And so it's how one is able to better co-opt these traditional healers along the lines of what you mentioned with priests and imams and others into trying to be a broader, holistic community to address these issues is something that I think is worth exploring. Don't know if anybody has thoughts about any of that.
I would agree with that. I think that engaging a culture in their culture is more of a recipe for success than kind of coming in with your own ideas about what you think they need to hear or understand to move forward.
Touché. All right, let's move to the next one then. So our 8th article, Migraine and Sleep Apnea, Insomnia and Sleep Patterns in the Hispanic Community Health Study, published in Headache in 2025. Dr. Spears will guide us through this one.
So this was an important study because the research was pretty sparse, looking at migraine prevalence and sleep comorbidities in an underrepresented racial and ethnic group in the United States. So that is really the background for this. And the idea was, were Hispanics and Latino adults in the U.S. At more risks for health disparities because of some of their other health outcomes and health issues that they suffer from. So data was collected between March of 2008 and June of 2011 from the Hispanic Community Health Study and the study of Latinos, a community-based study of self-identified Hispanos and Latino adults in the U.S. And exposure was self-reported medical diagnosis of migraine. Primary outcomes were obstructive sleep apnea with an apnea index greater than 15 per hour on home testing, and insomnia with a score of greater than 9 on the Women's Health Initiative Insomnia Rating Scale. And then the exploratory outcomes included self-reported sleep duration, timing, sleeping pill use, and naps. So they had a large number of participants, 16,325. They completed the questionnaires on sleep and migraine. Mean age was roughly 40 years. 52% were women and about 40% were men and had BMIs greater than 30 in the vast majority of these patients. The lifetime prevalence of migraine was about 16% in females and about 7.58% in males. Um, what they found was that those with migraine were more likely to be unemployed versus not, 51% versus 36%, and then to have a household yearly income of less than $20,000, 51% versus 45.5%. There was no association found between migraine and obstructive sleep apnea or napping, but those with migraine were more likely to have insomnia and use sleeping pills. And those with migraine had shorter mean sleep duration of 7.88 hours versus 8 hours, and they went to bed later at around 11:30 versus 11:17 p.m. The limitations of the study is that it underestimates prevalence of migraine since the migraine diagnosis was ascertained by a single item of self-reporting medical diagnosis, which is a specific but less sensitive assessment of migraine in the general population compared to other validated questionnaires. So the exposure assessments may be biased towards the null, and migraine participants defined in this study may reflect a more disabling migraine phenotype, more easily identified. Lifetime prevalence of migraine in male versus and older participants may have also been underestimated. So the conclusion, self-reported medical diagnosis of migraine is common in Hispanic and Latino adults, especially females. Migraine is not associated with obstructive sleep apnea, but is associated with insomnia in this particular population. And the implications, the findings are consistent with prior studies in largely non-Hispanic populations. Adverse social determinants of health were common in this population and associated with migraine, but did not materially influence the cross-sectional associations of most sleep-related outcomes.
Thank you, Roderick. So the study found an increase in reporting of insomnia and the use of sleeping pills among those who had migraines. How does that align with your own vast clinical practice? And what are your thoughts as to why this might be the case?
So I have seen this in my practice over the last 20 years, but I do have to say it's been graded more common in older patients, pre-migraine specific therapy era, than in the last decade, where we are not using some more off-label medications for treatment. My patients that have come to me on sleeping pills, most of them report they do have problems with insomnia, but they will also say that the sleeping pill helps with their migraine. And disrupted sleep is a trigger for migraine, so they take it for that reason too, to assure that they're going to get so many hours of sleep every night. So that's been the feedback I've received.
Interesting. Rashmi, Vanessa, thoughts?
Yeah, I mean, looking at it, the questions I had were, are those with migraine having insomnia because of uncontrolled pain? They're having difficulty sleeping? Is the migraine driving the insomnia and the use in the sleeping pills, or is it the other way around? They have insomnia and that's triggering the migraine. So it's, I mean, really hard to extrapolate there. That's my comment.
It's a great point. Yeah, Rashmi.
I agree with Vanessa because we know that sleep disorders can be a risk factor for migraine chronification. So I think it's hard. And also we see that, this is another theme that we already saw from one of the earlier articles, right? And that the correlation between being unemployed or having, a lower socioeconomic status and migraine burden, because the study also found that those with migraine were more likely to be unemployed and have a lower yearly income as well. And that likely also perpetuates their access to treatments and care. I don't know. I mean, this seems like a lot of things going on.
Yeah. I think that'll be the diagnosis here. A lot of things going on. No, good one. No, good points. Thank you. Awesome. So our last, but certainly not the least article is entitled Perceived Discrimination and Migrant-Specific Quality of Life. It's a survey in a Black/African American sample. It was published in the journal Headache in 2025. Dr. Spears.
Okay, so the background here is that African Americans with migraine face compounding challenges due to limited access to specialized treatments and discrimination in medical settings. leading to disparities in migraine care and outcomes. So little is known about how perceived discrimination affects migraine-specific quality of life, and so that's what this study looked at. So they looked at Black and African American adults with a migraine diagnosis, but only a number of 91 were recruited from a tertiary headache center between October of 2023 and April of 2024. Participants underwent testing using validated research tools to measure migraine-specific quality of life, lifetime perceived discrimination, and discrimination in the medical setting. Headache frequency and pain intensity were assessed using the MIDAS scale. And they looked for associations between discrimination measures and migraine-specific quality of life, controlling the headache, pain, frequency, and sex at birth as your variables. What they found was that higher levels of lifetime perceived discrimination and discrimination in a medical setting were significantly associated with worse migraine-specific quality of life outcomes, independent of headache frequency and sex at birth. Headache pain intensity, on the other hand, was significantly associated with poor quality of life across all models. Headache frequency and sex at birth were not significantly associated with outcomes, and discrimination indices and pain intensity accounted for between 28 and 32% of variance in migraine-specific quality of life. The limitations of the study, it had a very low participation rate of only 7.8%. Of those contacted actually responded for the study, and there was exclusion of participants missing all data for predicted and outcome variables of interest. Most of the participants lived in urban areas where migraine care resources were more accessible, limiting you can't generalize it to include rural areas or where there's more difficulty accessing care. Binary classification of ethnicity, lack of measurement of key psychiatric comorbidities was another limitation. And individuals who experience higher levels of discrimination may be less likely to seek care at a tertiary medical center. So they were underrepresented in this study as well. The conclusions were both discrimination and pain severity play a significant role in shaping the quality of life for Black and African American patients with migraine. However, the degree to which these factors shape quality of life and outcomes requires further exploration through studies with larger sample sizes and inclusion of psychiatric comorbidities. So the implication here is this study underlines the importance of clinician awareness of the significant impact of discrimination in medical settings on the quality of life for patients with migraine, particularly African Americans.
No, thank you, Roderick, for that an intriguing study. I guess one question I have out of curiosity before I ask you a couple of other questions I had was, have there been studies looking, again, going back to Rashmi's point about Asian populations, and this applies to Latinx populations as well, is have there been studies looking at differences within the African ancestry population, so to speak? And in stroke, we've done a lot of things looking at immigrants versus people who are here and all that. Are there differences with has that been studied at all? If you know, are there differences in headache reporting or any of that?
As far as I know, those studies have not been done looking at specific populations underneath the African umbrella.
Got it. Fair enough. And so one important finding from this study, of course, was that headache pain severity, as opposed to headache frequency, emerged as a significant predictor of quality of life. In your experience, how does this compare to prior research findings when it comes to racial disparities in pain management?
So I think that this is actually pretty consistent with other pain studies where they've looked at the difference between perception of pain in different ethnic groups, with African Americans being perceived to be in less pain than their white counterparts, receiving less medication for pain than their white counterparts, leading to misdiagnosis and mismanagement, leading to more disability, specifically for migraine patients.
And just like you, I suspect, I was struck by the low participation rate in the study, and just wondered that, again, people who experience discrimination, less likely to seek care at a tertiary medical center, likely underrepresented in this study. How do we address this, in particular when it comes to headache care and headache research?
Well, I think as researchers, we can definitely be more purposeful about reaching out to specific populations when we're conducting our clinical trials, and I think we should do that to try to be representative of the population. But as we talked about earlier, I think part of this is representation and people being comfortable when they see someone who looks like them. But on the other hand, also really educating our colleagues on our own biases that we all bring to these encounters and to these interactions with patients, and making it less stigmatizing to recognize we have biases, that we all have them, and that it should be part of our desire to get better as providers, like we do our continuing medical education. I think bias training should be part of that. So that we're better able to communicate with our patients and actually meet our patients where they are. And then it's just time and trust that these patients would have to get them through the door, and then it's a good experience, and not validating what's happened in the past or what they come in expecting to happen. That's not good.
Yeah, no, here, absolutely. Rashmi, Vanessa, any comments or questions? No? All right. Well, I just want to enthusiastically appreciate Dr. Cooper, Dr. Spears, and Dr. Singh for taking the time and effort to lend us their expertise today. Today, we're recording is Juneteenth, so many of these themes align with the theme of the broader day, but grateful to them and hope they'll come back again to also discuss new articles in the area of headache disparities and help us walk through those. So thank you so much for that. Just want to remind all of you that Disparities Dialogue falls under the umbrella of the Society for Equity Neuroscience, and that we have an annual conference, which we concluded in May of this year, for which you can join either in hybrid fashion. It could be in person or online. We have a scientific journal, Equity Neuroscience. Would love to see your papers submitted to Equity Neuroscience. Would love to have you as part of the editorial board if you're so inclined, or be a reviewer for the journal. We have a podcast, which is well subscribed, called No Brain Behind. And then finally, we have academic discourses such as this one, in which we try and bring experts together to try and dissect and guide us into the way forward to try and bridge these important disparities. Thank you all so much.
Thank you.
Thank you.